These are my funding and my disclosures. And another disclosure is that I'm actually not as against this testing as I might look like in this talk, because Dr. Helfand and I actually used Crawford's last meeting to write a book chapter about this topic that's published in the AUA curriculum. But for the purpose of this talk, I'll show you some of the limitations. So here we are. This is our mountain. And we start with PSA, then we want to do some sort of risk assessment, MRI, and then biopsy. And the question is, what's the role of genetics in the risk assessment? Well, there are many ways to roam. And about half of the ongoing or recently completed risk-stratified screening trials include genetic information in some form. And you can see here that many of these trials combine PSA with biomarkers, so for example, Stockholm 3 or 4K score, and then also with or without MRI, and then some of them combine with SNPs or without any of the other markers. So what else do we have in our toolbox? Well, let's look at them one by one before we get into genetics. The first thing we have is age. We all know that prostate cancer increases with age, and if you start screening sooner, as we did in the Göteborg trial in Sweden, you can halve the risk of prostate cancer death compared to starting later. We also know that race is an important risk factor, and risk of prostate cancer, as you know, is increased among Black men. Family history, well-known risk factor that increases risk up to twofold for prostate cancer. Baseline PSA, as Dr. Kupperberg mentioned, the good old PSA is really hard to beat. It's a fantastic marker. It's a really strong prognostic marker. And our trials in Europe, the ERSPC and the Göteborg one, have really shown that PSA screening regularly reduces prostate cancer mortality by about 30% after 22 years. And as we know from our studies in Sweden and also in Norway that we now replicated this in, is that the PSA in and of itself has a super high AUC. This is 90% with risk of lethal prostate cancer. So the bar is really high, it's really hard to beat. Biomarkers we also know can help us with risk stratification, and here's a systematic review of 49 studies of different liquid biomarkers that all show that they can reduce the risk of unnecessary biopsies and also increase the diagnosis of clinically significant prostate cancer. MRI, as we know, the new kid on the block, it's been a major game changer in PSA screening and early detection. And in Europe, there's now a large initiative that's called the PRAISE-U that includes different algorithms in different countries in the EU, and many of them use PSA algorithms combined with MRI and PSA density to reduce the risk of unnecessary biopsy. And this is also what we did in the Göteborg 2 trial, where we used PSA followed by MRI, and then we reduced the risk of unnecessary biopsy, reduced overdiagnosis, and kept the detection of significant disease. So given that we have all of this in our toolbox, where is the role of genetics? Is the solution in our genes? Well, if we look at our recent AUA SUO guideline, clinicians should offer PSA screening, so annual PSA and DRE, starting at age 40 to 45 for men who have increased risk, and that includes Black ancestry, germline mutations, or strong family history. And so what are those genetic mutations? Well, we know for sure that BRCA2 has an 8-fold increased risk, so definitely a yes for systematic screening of those men. And I would say also BRCA1. And there are other mutations such as HOXB13 and MSH2 and MSH6 that are also associated with increased risk, and screening can definitely be considered for those men. In terms of polygenic risk scores, we heard Dr. Helfand talk about these, and he mentioned that they can be seen as a quantified family history, which sounds kind of nice, and they can really help stratify risk. But as you might have noticed in his talk, most of these studies are associated with any prostate cancer, so incident prostate cancer, but not that many studies show strong associations with aggressive disease or lethal prostate cancer. And that's really the crux. So we really want to find the cancers that are aggressive. We don't want to find the indolent ones, because we know that prostate cancer incidence is 8 times higher than the mortality, so we don't want to overdiagnose prostate cancer. And so far, no germline SNP has really been shown to discriminate men at risk of aggressive from those with indolent disease. And with aggressive, I mean metastasis or lethal prostate cancer. And here's a study by Dr. Lilja's group where the PSA, or the polygenic risk scores, was not associated with lethal disease, and it did not add value above and beyond the PSA level in and of itself. So with those studies, should we throw out the genetic stuff, or can it actually add value above and beyond all that we have in our toolbox? So the Stockholm 3 test is an interesting test because it's a multiplex test that combines the age, the clinical information, the kallikreins, and the genetics. And if you add genetics, so these genes and the SNPs, you can see that it improves the AUC with 1%. So it does add something in addition to everything we have. When added to the 4K score in this study, also by Dr. Lilja's group, the polygenic risk score did not improve discrimination above and beyond the 4K score among men with elevated PSA. So a single PSA, the level in and of itself, was actually better than polygenic risk score of predicting lethal disease. And this is just showing the same thing. What's interesting and also an area for future exploration is PSA polygenic risk score. So whether we can somehow take into account the expression of PSA levels given a man's genetic composition and maybe adjust mathematically the values and combining them together. And that might be a way forward to, again, reduce unnecessary biopsy. So this is what I would conclude, that we need more studies demonstrating the contribution of the genetic information to existing clinical parameters and biomarkers in predicting lethal prostate cancer outcomes. And if you look at the uptake of screening just by using a PRS test, as was done in the UK, there was not so much enthusiasm, so only a quarter of those invited actually went and had this genetic test. So in conclusion, I would say, no, not every man should have a genetic test, but some men definitely. And this is what we concluded in our book chapter also, that definitely for men who have a strong family history and those who have a known family history of these germline mutations and those with Ashkenazi Jewish ancestry or history of multiple cancers in the same family. Thank you.